opportunity to talk with you all today. Very excited about this. And I know that, for many of you, just for many patients in general, getting a diagnosis of multiple myeloma is extremely distressing. And as you can see with all of the progress that we've had in the past few years, it's very overwhelming of a world to be thrown into. There's a lot of new terms. Sorry, here's my honoraria. There's a lot of new terms. There's a lot of new treatments that are out there, and there is just a wealth of information that can be very, very difficult to process. So today we're going to be talking about how we decide on what induction therapy we're going to use to preliminarily treat multiple myeloma. And as Audrey said, it's a very important step in the decision-making process because it is often the first line between you and a long remission. The therapy that you choose will affect side effects moving forward, will affect your outcomes for the foreseeable future, at least until the next big thing comes out. So all of these questions are often rolling through people's heads. How do we decide? I have highlighted the we in the statement because obviously I cannot speak for the entire myeloma community. I can give you my insights. I can give you, generally speaking, the insights of people that, or of the physicians that treat patients at Sylvester Comprehensive Cancer Center. We share similar, principles. And then the other reason that the we is highlighted is because this isn't just a decision that the oncologist makes. This is a team effort. We like to participate in shared decision-making, and the desires and the values of the patient and their perspectives are extremely important to making this decision. So to decrease some of the word salad, what we can do is try and organize a lot of these factors into three specific buckets, into how we might think about organizing our thoughts on induction therapy. Most of the information is related to the treatments themselves and the disease. So some of the things that you might be seeing more recently, the big developments are comparing triplet combinations to quadruplet combinations. They're the new kids on the block. In general, is more better. Clinical trials that might be available to you depending on where you're located. There are logistics that obviously go into all of these treatments. Some treatments are given via infusion, some are given via injection, some are just pills. And that honestly plays a pretty large role in what therapy we might select. Toxicity, I think, is underrated and extremely important aspect of choosing induction therapy. Some therapies, frankly, are just very toxic. And what's the point in trying to achieve a deep remission if you're going to be stuck with kind of negative side effects for the long term? And other things are related to provider experience. A specific center might be more versed and more experienced and might even get better outcomes providing one therapy compared to another. And so you might see just institutional preference might play a role into what the oncologist ends up deciding on. For the disease itself, I think all of the things on this list here ultimately boil down to disease risk. So again, all of these things, how fast the disease is growing, stratification in terms of risk, in terms of the ISS stage or the revised ISS stage, which takes into account those genomics and cytogenetics. If patients are symptomatic, if they have bone lesions, if there is impending renal failure, that play a part in what therapies we are able to recommend. Extramedullary disease, just kind of a sign of very high risk disease, and as well circulating tumor cells, kind of a herald for a type of myeloma we call plasma cell leukemia, where it's no longer limited to just the bone marrow, it's circulating in the bloodstream. And lastly, it's down to the patient, and certainly not leastly, how fit the patient is, what their performance status is, what they're doing on a daily basis, what their lifestyle is, and then really important is what their values are. There has to be a balance between the intensity of the treatment and then maintaining a livable and enjoyable lifestyle. Any comorbid conditions, the complexity of their situation, financial. When I say financial, I don't just mean the cost of the therapy, which can sometimes be very expensive in the absence of insurance, but I also mean just the logistics of getting to your appointments for therapy, because this is it for the long haul. So we have to decide on something that's sustainable, and that kind of plays into the social support. So we'll try and touch on all of these things throughout our short talk here today. Here's somewhat of a brief outline. I mostly just put this here to show which of the, the aspects we just highlighted are going to be talked about in even more depth. So the first thing I show here is somewhat of a basic treatment roadmap, mostly because I think it's helpful to have an idea of what your next few months are going to look like following the receipt of a diagnosis of multiple myeloma, just because it kind of gives some guidance. I will give the disclaimer, obviously, that every center is different. This isn't going to look the same at every center. But this is kind of more or less what we do, and what I'd encourage you to use is somewhat of a treatment roadmap to give you an idea of the next 12 months or so. The idea I want to highlight first is that I encourage you all, whether your first opinion came from Ola Langren or it came from Nina Shah, whichever expert in the field, would always encourage someone to get a second opinion just to get another perspective. We are all a very collaborative field, and we all like hearing each other's opinions. And I think in the age of telemedicine, there's really no reason to not ask for a second opinion, just if you have the time, obviously, to do that and the means to do that before you get started on therapy. So then induction therapy starts. Typically, at least with us, we like to do, we like to do all of our induction therapy up front without interrupting it with a transplant. We save the idea of the transplant for after the induction therapy. That initial induction therapy will take somewhere between 6 and 8 months for most people. There's a restaging, there's a collection of stem cells, and then there's a transplant. Generally speaking, after the transplant, there's about 3 months. This is, again, if the transplant is done. After the transplant, there's about 3 months or so before maintenance therapy is started, and that will generally go on for as long as people are responding or tolerating the maintenance therapy. That's kind of what it looks like. So what are we shooting for? As Audrey was saying, there have been a tremendous amount of advancements in the past, let alone 10 years, 5 years even, regarding myeloma. So traditionally speaking, there are these hard endpoints of overall survival and progression-free survival. The fact of the matter is that people are doing so well with new induction therapies that it takes a very, very long time for us to read out the results of trials in terms of overall survival and progression-free survival. When the median PFS is coming out to 5 or so years for every new trial, it seems like it's difficult to wait for us. When we see a really good combination, it's difficult to wait the 5 years needed for like a PFS result to read out that we can get regulatory approval for a new and promising therapy. So MRD negativity, which is something that we're going to be talking a lot about, is really something that has come to the forefront. And then by virtue of that, MRD negativity sustained across multiple measurements. So just briefly, if you haven't heard of MRD yet, you will. It is both a very simple topic and also a very complex topic. And in its simplicity, it really just means that we are shooting for the lowest amount of disease possible with our therapy. We're trying to drive it down to as little as possible, because it stands to reason that people that have the deepest responses are going to do the best. And so by the definitions that we have today for MRD negativity, which stands for minimal residual disease, our sensitivity level is defined as having a negativity below 1 in 100,000 cells. So in other words, if you look at 100,000 cells in a flow cytometer or by next generation sequencing, you are considered negative if you have less than 1 in 100,000. That's the sensitivity level that we go for. And in some of the trials that I've highlighted below, many of which we'll be talking about individually, all of these curves just show the split between the MRD positive patients and the MRD negative patients. You clearly see here via the Kaplan-Meier curves that the negative patients are doing far better over the long term. This has been borne out in meta-analyses as well. So in a study done by Langren over on the left, you see with the bars essentially left of 1 that the hazard ratio is lower for patients that achieve MRD negativity across multiple studies. And then on the right side, a study done by Munchinal, again, another meta-analysis of a number of studies all combined together to look at the results of MRD negativity, sees similar outcomes. And the field in general is trying to push for MRD negativity to be used as an endpoint for these trials instead of PFS and OS, mostly because if it looks like MRD negativity is a good surrogate for the hard endpoints like PFS and OS, then why not use it in our clinical trials so we can have an answer sooner if a therapy is going to be good and whether it should be used or at least approved sooner for our patients. This is a slide, I don't know if you guys are on Twitter, but I follow Rahul Banerjee. He's great. He's from UCSF. And he did this really nice summary slide, actually of a study that was done by the Spanish group looking at the Pathema GEM 2012 data. It's essentially a trial looking at VRD and induction, VRD and transplant with a couple of different conditioning regimens for the transplant. Ultimately, VRD and transplant. And this is a pretty common approach across the world. And I think the important piece here is that there are these traditional criteria for response that you've seen a lot of people refer to: partial response, very good partial response, complete remission. All of these things seem to pale in comparison to MRD testing. In other words, if you are MRD positive, that response criteria, the PR, the VGPAR, the CR, it did not matter. All those curves are superimposable. What really only mattered was whether a patient was MRD negative or MRD positive in this trial. And again, it goes to show that we really should be using this. I mean, pretty much as a standard of care for patients at a response assessment. So I would advocate that when you do finish your induction therapy, that you ask for MRD testing if it is not already offered to you. It is one of the biggest predictors of response that of long-term outcome that we can have. This is actually data from the same trial, the PATHEMA Gen 2012, just sort of in a different format. And on the left, what you're looking at are the MRD negative patients across all three risk groups, so the RISS 1, 2, and 3. And essentially what we're looking at is that MRD negativity, the attainment of it following the induction therapy, kind of get rid of that extra risk that you might have with high risk disease. So all of those patients, regardless of their risk, they did equally very well if they achieved MRD negativity. On the right side, what you're looking at are the same trial, but these are the MRD positive patients. And here you see that now the risk groups start to matter a little bit more, with the high risk patients doing significantly worse than the patient that had lower risk disease. Again, all MRD positive in that case. Now, I know I'm touting MRD negativity, but there is still a lot that we don't know, and there are a lot of limitations, and this is probably why it hasn't been fully adopted by the rest of the field just yet. One of them is, quite obviously, this is a bone marrow biopsy based test, and so if you are just sampling one area of the bone marrow, say you're going back in the hip over there, we're leaving a lot of the rest of the body unsampled. And myeloma is a heterogeneous disease. It could be hiding in other places. You might have a false MRD negative assessment if you are basing it just on one bone marrow. So there are strategies to kind of aggregate that, to maybe get a PET scan at the same time to see if you can catch any of those outliers, but that is a limit. And then obviously the limit of detection, we're only as sensitive as our tests are. So there's always going to be a degree of uncertainty there. There's data coming out that show that not all MRD negativity is the same. Is MRD negativity attained after a transplant the same as MRD negativity that's attained after, let's say, a 3-drug induction? Seems like the answer might be no, but more on that to come. And then it's looking at MRD at just a single point in time. Is that adequate? Maybe MRD can change over time. Maybe the changes in MRD status are more important than just looking at it at a single point in time following your induction therapy. I will touch on this very briefly because we're going to come back to the Forte study later. But just to give you that idea of how there are different levels of MRD negativity, how a single time point isn't quite going to be adequate. On the left, what you're looking at are the post-therapy responses, essentially right after they finish therapy with KRD versus KCD versus KRD with transplant. This is a really pivotal trial that we will discuss in more detail, but I do want you to look and see that at least for the KRD arms, those two on the right, the MRD negativity rates are quite good, 58% and 54% each. So looking at just that alone, you'd say, hey, either of those is really great. But then if you look on the panel on the right side, mostly, I would ignore the Kaplan-Meier curve for now, but mostly with the circular bar chart there, you see that after about a year of those patients that had MRD negativity, patients that got a transplant, the KRD plus the transplant, seem to sustain that MRD negativity for a longer period of time compared to those KRD patients that got KRD alone without the transplant in the middle there at 54%. So it seems like there is a difference, one in therapies, and then secondly, in terms of how often we check MRD negativity.
Hey, Dr. Diamond, if you don't
Sure.
mind, can we just briefly, some of these patients are very new, so I want to go over what KCD is, KRD.
Yes.
Let's talk about what that is.
Yeah, I hesitated about whether I should put this here or later. I will be talking extensively about what each of these regimens is.
Perfect.
But for starters,
sorry, then.
no, you're absolutely right. It is confusing. And I would just say, depending on the therapy, depending on the transplants, not all MRD is equal. Let's go with that. And then we'll come back to the Forte study.
Perfect.
For sure.
Okay, thank you so much.
And lastly, a little plug here, how MRD changes over time. This is a study that we did back at MSK before we left and came down to Miami, basically looking at 100 or so patients that received lenalidomide maintenance therapy, again, after induction, but showing the importance of measuring MRD over time. We looked at this MRD testing every year for a number of years, up to 5 years after starting maintenance therapy. And as you can imagine, there on the left, what we're looking at here is a curve that actually starts at 2 years. So it doesn't start, at the time of maintenance start, it starts 2 years afterwards. And we see that patients that had MRD negativity sustained for 2 years, none of them progressed as far as we were watching them. That's really good. On the other hand, obviously, patients that had residual disease at 2 years were more likely to progress. It gets more complicated than that, though. When you look on the right, if you split that curve of patients that had residual disease into people that at 2 years had lost their MRD negativity, in other words, patients that had attained MRD negativity at the end of their induction and subsequently lost it at some later time point, those patients actually did worse than the people that had sustained positivity. In other words, stable positive disease. And this kind of suggests, again, one point in time is not good enough. And secondly, that MRD positivity in and of itself may not be necessarily an awful thing as long as it's able to sustain itself over time. So if you have an MRD positive result and you see it staying that way without changes in the M protein, without other changes over the course of a couple of years, that seems to be a pretty good outcome as well. So again, there are still a lot of things to hammer out with MRD. Suffice to say, I still think with all of these data, that is one of the strongest endpoints that we should be aiming for. So move on to another choice. So how do we make these choices? I know I talked a lot about MRD negativity. I'll speed it up and talk about some of the other things. So attrition is a big one. The idea is essentially that as people get more and more lines of therapy, they're more and more likely to drop out, either for reasons of toxicity or for progression of disease, or unfortunately for death. And so what it means essentially is that there is no reason really to save your best therapies for later. There's no reason to keep them in your pocket. There are new therapies that are being approved very, very often, each more promising than the last. And so I don't think, based on this, that there's any rationale for saying we'll save it for later. I think use your best shot up front if you can. This is a slide, by the way, from Dr. Lang. I think it's very powerful, and so I include it here. Another consideration is obviously toxicity, and we'll be trying as we go through all of these regimens to talk about the different toxicities of each of these drugs to help you make a decision. What you're looking for here on the left are that as lines of therapy increase, as indicated by the color of the bar, patients are more likely to experience more and more cumulative side effects, whether they're neuropathy, whether they're anemia, whether they're fatigue. Those side effects are additive over time. And so really trying to minimize those as you go through the lines of therapy is something that I think should be of prime importance. Okay, so I know I had jumped ahead of myself a little bit before. Here are all the regimens that we're going to be talking about today and what each of these drugs are and how we kind of decide who gets what. So in the literature and sometimes in other people's presentations, you'll see these regimens considered like transplant eligible inductions versus transplant ineligible inductions. For a number of reasons, I don't really like to put people into buckets of being transplant eligible or not, mostly because at academic centers, it's not me making the end all call on that. It's the BMT physician, the transplanter that's doing that, but also because I don't think that by definition, everybody requires a transplant. So instead, I just like to think of patients as being either fit and can handle pretty much anything versus frail, and maybe we should take things a little bit slower. So the first kid on the block is VRD. I know this trial came out in 2017 published, but really people had started using VRD early in 2011. This is a combination of a proteasome inhibitor, which is Velcade or bortezomib. Revlimid is the trade name for lenalidomide, which is a pill, and dexamethasone, which is a steroid. And this kind of established that we really shouldn't be using doublets in multiple myeloma induction. We should really be using at least triplets. I would say that the regimens have changed a little bit in their structure in terms of how often they're given and the doses, but the basic backbone is the same. And so patients here were given either VRD or RD, and then they went on to lenalidomide maintenance. This is for patients that were not intending to have a transplant. And for 525 patients, just can be relatively brief with this trial, but the PFS was far longer for patients that were receiving VRD. Kind of a no-brainer. This is the therapy that has become the backbone pretty much everywhere in the world and across the United States, and has been for quite some time. And you can see there, I mean, again, there's the curves, you saw the PFS, so it's not a surprise that the VRD patients are doing better.
Hey, Dr. Diamond, just one more thing.
Sure.
Can you explain PFS versus OSS and kind of explain why? I know you explained the MRD negativity earlier, but
I'm happy to, yeah.
Awesome, thank you.
Sure. So these are the hard endpoints that we have, PFS and OS. So PFS is progression-free survival. So this is essentially the time from the end of the therapy that a patient can expect to be free from disease. So we measure that as the time from the end of therapy, actually, I should say from the start of therapy usually, until the patient then has a progression event. So in this case, let's say the median progression-free survival was 43 months. That means that half of patients started therapy and 43 months later had a progression event versus 30 months in the RD arm, so the doublet arm. And then on the flip side, overall survival, which is notoriously difficult to measure in multiple myeloma, partly because people are doing so well and because there are so many lines of therapy that might kind of change the results and how we can possibly measure and compare between patients, is the same concept, except replace progression of disease with survival of the patient. So obviously the OS should be far longer, but we often are not able to measure it, at least in the induction setting. This pivotal trial, the IFM 2009, was another one looking at VRD, but here we have VRD plus transplant. I will spend a couple of minutes on this trial, mostly because I think it's one of the most well-designed trials that have been performed in multiple myeloma. It actually guides a lot of our clinical decision-making, and I can kind of show you how. This was a trial where the French group actually combined with Dana-Farber looked at 700 patients that were all eligible for a transplant. And they randomized patients to either receive 8 cycles of VRD, followed with the option to have a transplant at the time of relapse. So in other words, a delayed transplant, versus people that had an upfront transplant. So it's important to note that it's not transplant versus no transplant, it's transplant versus delayed transplant. And so this was followed again by 1 year of lenalidomide maintenance. So at the time that anybody relapsed, it was up to the investigator to decide whether that patient should go for a salvage transplant versus having some alternative therapy, although the transplant was recommended. In this trial, they measured MRD negativity, here even more sensitive than what we normally do in clinical practice. They were looking down to 1 in a million cells. And that kind of affects some of the rates here. You would expect if you're looking deeper, then you're going to have less patients that meet that. So the rates are going to be a little bit artificially lower. At the same time, they only looked at patients that achieved a certain level of response, and so that kind of artificially inflates things. So there are some caveats here. Needless to say, though, when you look at the curve that I'm showing you here, just at the MRD negative patients, I want you to focus at the top 2 lines there. These are the patients that both achieved MRD negativity and either had a transplant or did not. And what's really important here is that those curves are very similar. Patients that had an upfront transplant seem to do pretty closely as well as patients that had a delayed transplant, as long as they achieved MRD negativity. And that's the big takeaway from this trial, is that it didn't seem like there was a huge degree of benefit to be had in doing a transplant following the achievement of this very deep MRD negative response. And so that kind of guides some of our decisions moving forward. Furthermore, if you take the MRD alone out of it and you look at just on the left here, so this is PFS2. This is essentially the time from when a patient starts their initial therapy until they progress on their second line therapy. And that's important because it kind of says, you've got an extra line of therapy in there. Are people doing any worse on their next line of therapy if they miss out on the transplant? And it's just, you can see the curves are completely superimposed here. There is no difference. And then on the right, we're blessed to have overall survival data after about 10 years for this trial. It's very hard to get overall survival data. This trial luckily has it for us. And you see there, regardless of having the transplant up front or delayed, the overall survival is the same. That's really important. That kind of tells us that transplant is a really good therapy, but it's kind of like an additional therapy, not necessarily modulating your initial response. It kind of seems like there might be a use for it in certain patients, but people are doing very, very well, regardless whether they get it up front or whether they get it delayed. And I had this question come over on Twitter the other day with regards to MRD negativity, where somebody said, well, we've got this really good test. You're talking about how great MRD negativity is, but what do we do with it? How do we make treatment decisions with it? And so I will say that although this is definitely institution-based and not a standard of care everywhere, what we generally do is that if a patient is able to achieve MRD negativity with their induction therapy, we're generally pretty comfortable in allowing the patient or encouraging the patient to consider deferring their transplant. It doesn't seem to be all that beneficial if you already achieve MRD negativity. So why add extra toxicity if it's not going to do that much benefit? We say collect the stem cells, keep them in your back pocket. But this is how we use MRD negativity to potentially change our treatment approaches and kind of individualize therapy based on the individual patient's response. So moving forward, and now kind of the focus is, well, okay, good. If MRD negativity is great, we saw what those rates were with VRD and transplant. How can we improve on that? So the next kid on the block was kind of, I don't want to see an upgrade from Velcade, but kind of a cousin of Velcade. This drug is called Kyprolis or carfilzomib, as we call it. It's an infusion. So this is the big difference. Whereas Velcade can be given as a subcutaneous kind of shot in the belly, very easy to give. Kyprolis, you need to give it as an infusion. So you do require an IV to get this drug over the course between half an hour to an hour. So one of the trials that I highlight here is a phase 2 study that was done over at the NCI, where they looked at KRD with 2 years of maintenance therapy for 45 patients. And impressively, 62% of patients were able to achieve MRD negativity with KRD alone, no transplant, just KRD and maintenance. Moving forward, I promised I'd come back to the Forte trial, and I'll show you that same slide as before. This is another really pivotal trial, very well designed, really like this trial, answers some really good questions. There were 3 arms in this study. I sort of ignored the KCD, which is cyclophosphamide, instead of getting the lenalidomide pill, mostly because it's not an approach that we do very often in the United States. So try and focus just on the bottom 2, which really come down to, can you get KRD for 12 cycles with no transplant and compare it to KRD with a transplant? And then there is a second randomization we won't really touch on today, where they either where patients were randomized to either receive a single drug maintenance as a standard of care with lenalidomide versus getting a combination maintenance therapy. But and there it goes. So here's that slide I showed you before when we were talking about each of those arms. Again, you can sort of throw out the one all the way on the far left, the KCD, and look at the KRD with transplant in the middle, and the KRD 12 months on the right side in this left panel. And what you're looking at is an intention to treat analysis. This is all of the patients on the study. So 58 versus 54% achieving MRD negativity at the end of that treatment. That's superb. And sort of is in line with that phase 2 study I showed you with the KRD alone, where about 60% or so achieved MRD negativity. So really nice to see that validated in the phase 3 trial. On the right side, now here was the kind of wrench that got thrown into our whole transplant talk. It seems like people that got a transplant were more likely to sustain that MRD negativity over the course of a year. So it's definitely food for thought. That is why there is certainly no definitive answer on how transplant can fully modulate having that sustained MRD negativity, and why it's always a topic of debate. But needless to say, it seems like the more therapy you give, KRD is very potent. You add a transplant on top of that, it seems like it's going to push you to achieve a more sustained good outcome over there. On the right, at that PFS curve, what you're looking at it's actually highlighted at the 3-year PFS rate. So this trial hasn't fully read out yet. We haven't reached the median PFS, in other words, the point at which everyone crosses that 50% threshold. But we have the 3 and 4-year rates. If you ignore the curve for now and just look at the text at the bottom, the 4-year rate is the most recent data that we have. And we see that for the KRD12 and the KRD transplant arms, the 4-year PFS rate are 56 and 69%. So in other words, at 4 years, 56% and 69% of patients respectively are still doing just fine, have not progressed with either of these regimens. So this is really phenomenal data. I would be remiss to not talk about the Endurance trial, because it is a very important trial, and I think you guys should be aware of it. Depending on the center that you're treated at, there's going to be a lot of debate about using KRD versus VRD in the frontline setting. There are a lot of giants who conducted this trial who have done an enormous amount for the field. And so what they tried to do here was to try and answer this question about which of these 2 regimens was better. I will say just right off the bat that we do have some issues with the trial. I think that although it tried to answer a very important question, it honestly did not succeed in doing so, just based on some of the criticisms that we have. So as a disclaimer, I will just tell you that the basic rundown is that there's a huge number of patients included here, over 1,000. It was only for standard risk disease. There was no intent for an autologous stem cell transplant. And then obviously half got VRD and half got KRD, and then maintenance was following that. So you look at the curves, and the conclusions were essentially that the two studies were not necessarily different, that one was not better than the other, that patients that got VRD did just as well as KRD, or you could say it vice versa. And they have here on the left here the PFS curve for that. And I guess some of the issues that I guess I'll start just talking about. So the MRD negativity rates are a lot lower than you would sort of expect for either of these two treatments. So here, we were just talking about rates on the order of 30%, 50, 60%. Here we're looking at 7 and 10%, which is a little uncharacteristic. Some of the toxicity profiles are things that you would expect. We'll talk more in depth about which drugs cause what toxicities. But obviously with carfilzomib, some of the toxicities that we're seeing were more related to the vascular side effects. So people had heart failure, people had other arrhythmias, people had pulmonary edema, things related to fluid, essentially. And then in the Velcade group, people had a lot of neuropathy, a lot higher neuropathy. So I will say here that they only reported grade 3 neuropathy, which is severe neuropathy. Grade 2 was not reported, which I think is unfortunate. Do I have this here? Yes. So this is why I say that's unfortunate, because this is the CTCAA. This is how we define the severity of symptoms. And as you can see, grade 2 neuropathy is still pretty bad. That's moderate symptoms that do limit the activities of daily living. This is where people are going to have some trouble, buttoning their buttons, perhaps playing an instrument that they like to play. It's not a joke, and it's not something to ignore. So I do think that knowing those grade 2 rates would be helpful. Instead, we have the grade 3 rates. We see that it's 8% versus 1%, and these are severe symptoms that limit self-care. So other criticisms, part of the issue was that patients on either arm could change their treatment and still be included in the analysis. So in other words, if you were on the VRD arm, you could switch to another therapy, say something that had Daratumumab in it, and still be considered as being in that VRD arm. And even if you control for that and you remove all those patients from the trial, what you're effectively doing are pulling out all of the people that have either bad biology or high sensitivity to toxicity at a higher rate from the VRD arm than from the KRD arm. So many more patients were not able to continue on the VRD arm than on the KRD arm. And then on top of that, in terms of giving the KRD, so again, we mentioned that this is an infusion. So normally here at Sylvester and certainly at MSK, it's our practice to only give about 250 cc's with just the first dose of carfilzomib of fluid. Now 250 cc's is about a can of Coke. Over the course of this trial, when patients were getting KRD, if they got every single dose, they were getting 13.5 liters total. And so a lot of the side effects related to fluid overload, like heart failure and pulmonary edema, you can imagine could have been stopped if less fluid was given. On top of that, this plays into the fact that some of the institutions that treated patients on this trial only treated maybe one patient. And so less experience might lead to some of the issues that you see with KRD. So what I would say is, there's a lot of debate about this. A lot of people will use this and say, it's fine to give VRD, we should just do it. I think that if anything, VRD, you can conclude that VRD and KRD are just as good as each other, but there are different side effect profiles. And if you're trying to avoid neuropathy, then it makes a lot of sense to avoid VRD. So moving forward then from there. Now, I promised I'd talk about quadruplets because this is the new kid on the block. This is what a lot of new academic centers, or what a lot of academic centers are moving to. Again, the interest here is, we know MRD negativity is good. We know deep responses are good. How can we deepen them? And so most of the strategy involved in trying to achieve that are by adding drugs that have really good side effect profiles, something that's very tolerable to see if we can deepen the response. And in this case, that drug is oftentimes Daratumumab. And this is a drug you'll hear a lot about. It used to be given as an infusion. This is a monoclonal antibody. It's a drug that it's an antibody that binds to your myeloma cells and directs your immune system to attack it. It has a very good side effect profile, and it's very easy to tolerate. It used to be given, well, it still is given via infusion. So in other words, you get it via IV. It's even more convenient now because there is a subcutaneous injection, so you can kind of get it the same way as the Velcade. That makes things a lot easier and a lot faster. So it's a very much preferred drug to be using these days. So the Griffin trial was a really nice trial looking at the addition of daratumumab to that RVD backbone. And here, all the patients on the trial got transplant. And then again, there was a difference in the maintenance regimens that we don't necessarily have to go into today. So just making the decision between adding Dara versus not. So on the left, I kind of told you about the importance of maybe not taking too much stock in the traditional response criteria, those complete remissions, those very good partial remissions. But what you see is a nice trend that over time, as people were getting this therapy, every time they measured, the responses were getting deeper and deeper. So that's a good thing, obviously. I think more importantly, on the right side of the screen, what you're looking at are the MRD negativity rates following a certain time point in the treatment schedule. And so I think the important ones to look at are the end of consolidation versus the last follow-up. So this is essentially, the post-transplant versus the last follow-up on the trial. And the rates there are 47 and 51%. So that's really nice to achieve, MRD negativity in this high rate of patients. We always have difficulty comparing results across trials because, there are different patients, there are different centers, different methods of measuring things. So you can never really be definitive and you can't make conclusions, but you can make associations. And so what we see here is that Dara RVD with a transplant can give you a rate of MRD negativity of about 50% or so. What we saw with KRD alone or with transplant where the rates were in the 55 to 60% range. So I kind of just throw that there and say, they are similar for the most part. What I do want to highlight, though, is that for patients on this trial, neuropathy was a big issue. So here we have reports of any grade neuropathy. So luckily, the authors included grade 2 neuropathy as well. And so here, neuropathy was rampant. So 60% of patients in the VRD arm, 74% of patients in the Dara VRD arm. So, that's 3/4 of the patients on this trial were suffering from neuropathy if they received the full extent of their therapy. So I think that is a big price to pay for an MRD negativity rate of 50%, given that KRD on its own has been shown to get similar rates. So my 2 cents, if you're trying to weigh the depth of response to a certain therapy, you always have to weigh it with the side effects. And so, can you do KRD and a transplant or KRD without a transplant and achieve similar rates of response while avoiding neuropathy? I think our approach would be to consider doing that if we could. Then in the last couple of minutes here, the newest kids on the block. So of course it stands, sorry to apologize for my dog in the back playing with his toy. The newest kids on the block are just to upgrade again that Velcade into Kyprolis, so this infusion therapy. This was a trial that was performed by us over at MSK, just a single arm study, so not randomized, but looking at the combination of Dara with KRD for 41 patients. What I want to highlight here is the endpoint. So here we're starting to realize PFS takes too long. We have really good data for MRD negativity. What we ended up doing was setting the endpoint of this trial to say, what is the MRD negativity rate at the end of that 8 months of induction therapy? And that's it. We don't wait any longer. We publish the results and see if we can get the community to buy in based on the MRD negativity alone. And so patients on this trial, half of them had high-risk disease. Again, the endpoint was MRD negativity, and a lot of the patients did not go for a transplant following this. This is the basic rundown. Every row is a separate patient. All 41 of them are included here. And then each column is a measurement of response after each cycle of therapy. And so the dark green is what we really want to achieve, that is MRD negativity. And the important thing to note here is that 71% or 29 of the patients that got this therapy achieved MRD negativity. There was no grade 3 neuropathy. There was one case of essentially a patient having a heart attack. Hard to say whether or not this was related to therapy or not, but that was the side effect profile that we saw in this. Also, really nice study. I really, really like the study that's being done by Luciano Costa down at the University of Alabama. This is another implementation of Dara KRD. They have a really nice design where patients all get Dara KRD here with a transplant baked in. Now, the nice thing is that they measure MRD negativity at a number of times throughout the therapy. And if patients had 2 MRD negative measurements in a row, then they would de-escalate and come off of treatment and then go on to maintenance. And I think that is honestly probably one of the best, or at least one of the biggest questions that we need to be answering in this day and age, where everybody is achieved, or where a huge number of people are achieving MRD negativity. Does everybody really need the same intensity of treatment? Does everybody need the same length of treatment or the same length of maintenance? So we don't have all the data yet, and it might take some time to have the full results, but I have some preliminary data to show you. And the big number to look at is that here, post-transplant, post-consolidation with Dara-KRD and transplant, 82% of patients achieving MRD negativity. So I think that is kind of huge, and this should be one of the regimens that is going to be coming to the forefront. Now, all of these regimens that we talked about today are in the NCCN guidelines. So what this generally means is that if you get put in the NCCN guidelines, then for the most part, insurance companies should cooperate if the regimen is being considered. And you see that all of them are included here, including Daratumumab KRD. The recommendation I don't have up on the screen is that Dara-KRD is really only considered useful with patients with high-risk myeloma. So oftentimes if a patient has standard risk disease, which you'll have to talk about with your oncologist, Dara-KRD is generally not an option for standard risk disease. The very last thing, in about a minute, I promised that I would talk about what happens if you're considered frail or not transplant eligible. There is the trial called the Mrd trial, which is a really, really nice trial that looked at the combination of Daratumumab, Revlimid, and dexamethasone, so the steroid pill, without any of the proteasome inhibitors, so without the bortezomib, without the carfilzomib, without the transplant. So for people that really were sort of in a frail state of mind, state of body, that wouldn't be able to tolerate more frequent visits, that wouldn't be able to tolerate the transplant, can we give them a softer therapy? And it turned out here that DRD is quite good. I'll just skip ahead to the PFS at the bottom right there. So at 48-month PFS, people getting Dara-RD. So at 4 years, PFS rate was 60%. I mean, that's quite nice. And then even then, the MRD negativity rates seem to increase over time. This is a continuous therapy. So by that 4-year mark, 30% of patients on the Dara-RD arm were achieving MRD negativity. So really, really nice option as soft therapy, easy to give. At the end of the day, after about 8 months or so, the Daratumumab becomes a monthly injection. So just once a month, you're coming in for a shot under the skin. It's very doable, and the side effect profile is quite nice. So we really do like this trial and this regimen for people that aren't able to handle stronger drugs. So I tried to touch on a lot of these topics. It's a lot to cover in 40 minutes. So I suspect there's going to be a lot of questions about this. I'd be very happy to answer any of the questions that you have. The idea being that we need to try and balance the strength of the treatment, the risk of the disease. We don't want to overdo it, but we don't want to underdo it. And then also the values of the patient. What side effect profiles are tolerable? How often can I make it to the infusion center? How much social support do I have? And the lifestyle. All of these things come together into how we try and make this decision together. So I thank all of the people down here, the University of Miami and Sylvester Comprehensive Cancer Center, all of our supporters, including Myeloma Crowd. And with that, I will kind of open it up to questions. I'm sorry I didn't leave more time for questions, but I'm happy to stay on longer if you guys are.
Perfect. Thank you so much. And I'm glad we got a little cameo of your dog in the background.
Yes. You heard him squeak. That's what he looks like.
You wanted to be a part of it. No, it's great. Yeah, I'm glad that you can stay on a little bit longer because I'm sure there's going to be many questions. I have several of my own. One of the things that I wanted to talk about quickly could you give a brief overview about how drugs are approved as induction therapies? I think when I learned about it for the first time, I was quite surprised about, how long it takes to be approved as a frontline therapy. So if you could just talk to that briefly.
I will do my best. The person at our center that can answer this the best is Diko Kazanjian, who used to work at the NCI and worked with the FDA. So he definitely has the insider information on this. But the basic gist is that most oncologic therapies are approved by the FDA on the basis of side effect profiles in combination with showing a PFS benefit or an OS benefit. PFS is usually accepted as a surrogate for OS, again, because we said how hard it is to look at OS in multiple myeloma. So generally speaking, if a combination shows that it is well tolerated and that people are able to achieve a better PFS versus the standard of care, the FDA will approve it. And then following that, there's a little bit of a delay in getting that out to the patients. There's a little bit of a distinction between FDA approval, formal approval, and then getting put in the NCCN guidelines. So the NCCN guidelines are more of guidelines that oncologists can use to direct their therapies. If a therapy is put in there, in general, but not 100% of the time, insurance companies will usually work with that doctor if they want to prescribe that medication because it is recommended in the guidelines. But that is not full approval from the FDA. So for example, as we were talking about Dara KRD, it's now in the guidelines. You can negotiate with insurance companies, generally speaking, to be able to give that to people with high-risk disease, but you won't find the FDA approval for that.
Okay, wonderful.
A little bit more of a hurdle to get to.
Yeah. And then is it true that all therapies have to be approved, for relapsed refractory, and then it moves up the line? Or is there treatments that are right out of the gate approved as induction therapies?
That's a really good question. I am racking my brain. I can't think of any therapy in current history that was approved in the induction setting, in the frontline setting first.
Okay.
It's not a requirement. It's just that oftentimes being able to justify treating patients over the standard of care, you really want to know that there's a known benefit. And so people will usually go to the multiply relapsed refractory setting where there's not much else of an option, show the benefit there, and then slowly move things up to the front line.
That makes sense.
Yeah, in the end, it takes longer, but that's usually how things go.
Okay, wonderful. If you want to stop sharing the screen so they can see you.
Oh, yes.
Really, I forgot to tell you that. No, it's my bad. Let's talk a little bit more about the trials that you mentioned. You did an excellent job, by the way, and I learned a lot. So thank you for that informative presentation. Carol is wondering about the Maya trial. Did it include high risk and also FISH results such as like amplification 1Q? She's really concerned about patients that are high risk disease above 80 and older.
Of course, I think that's a really big concern and a really good question. So the Maya trial did include patients with high risk disease. When we look at the subgroup analyses moving forward, there aren't a huge number of them, especially with amplification 1Q. There aren't a huge number of them for us to be able to make really sound comparisons between the DRD and the RD arms. I mean, suffice to say, people with amplification 1Q do worse across all treatment paradigms for the most part. And for those of you that don't know, this is actually complicated even among oncologists. There is gain of 1Q, which is usually one extra copy of the chromosome 1Q. And there's amplification 1Q, really confusing, which is anything more than that. So usually 2+ copies. So long story short, more 1Q is bad. So amplification 1Q does probably among the worst of all of the high-risk cytogenetics. Just a small number of patients included in the Maya trial. And I agree, there should be more efforts placed on trying to find something, even better than DRD for patients like that. And I do agree that, if I had a patient, regardless of age, that had, a high-risk marker like that, I would certainly be trying to personalize and tailor treatment and try and escalate things as much as I could possibly do within reason.
Wonderful. Thank you. And that it shows, if you're in that situation, it's so important to be connected with the specialist because they're going to have the latest and greatest that's going to be able to help you in those kind of situations. What phase of trial is the Maya in?
So, I mean, right now, I think it's still reading out. Don't quote me on this because I honestly am not 100%. It was a phase 3 trial. I mean, I think they hit their primary endpoint, so they are published, but I could be wrong on that.
Okay, no, that's fine. I was just more wondering about if patients could ask their doctor about this at this point in time, if they are in the situation where they are not able to receive a stem cell transplant, if they're able to talk to their doctor about this regimen.
Oh, absolutely. I mean, I think that anybody that treats myeloma should know the results of that trial because, I mean, it's a fantastic option for those that can't tolerate transplant. I will say right off the bat, though, that again, all of these drugs are pretty well tolerated. They really are. And so I have treated people that are 80+ with KRD, no problems at all. So
Mhm.
there are kind of general guidelines, and also, again, based on how willing people are to come in for those infusions. So age is just a number. You can give stronger regimens to patients that are older, whether or not somebody is considering them transplant eligible or not.
Okay, thank you. Let's talk about the Forte trial as well. Did that include high-risk patients?
It most certainly did. The Forte trial, though, as amazing as it is, we really are like every time there's a national meeting regarding myeloma, everybody's always tuned into the Forte results because it answers such important questions. But they do have subgroup analyses. I really think that we need to see the final data, because a lot of the time, every single presentation only presents a certain aspect of the trial. It's really hard to get a global understanding of the data. I can say that it looks good. Certainly, in a part of the trial that we didn't talk about, which is the maintenance setting with the KR versus R maintenance, it looks like KR is doing really well, especially in high-risk patients. So I would take that away from it so far. But in terms of making like formal conclusions, I wouldn't be able to say exactly. But I am sort of starting to consider doing KR maintenance for people with high-risk disease for sure.
Interesting. There's actually a question about maintenance, about using lenalidomide,
Yeah.
Revlimid, as a maintenance therapy. There's been talks too about including Velcade as maintenance therapy
Yes.
for those at high risk. What are your opinions about that, especially if they received an MRD negative result?
Oh, especially. Okay. So a couple of questions there. Really good question. There is a lot of discussion about using Velcade plus lenalidomide in the maintenance setting for people that have high risk disease. A lot of that information comes from studies that didn't necessarily look at VR versus R maintenance. They're kind of extrapolations of how people did. This is, with older trials, this is like comparing VRD with Velcade plus chemo.
Oh,
So
wow.
they're kind of a reach. That's not to say that they aren't based in reason. They certainly are. I just think that there is a little bit less data to support doing that. And then obviously part of the problem is that if you're getting Velcade for an even longer period of time, you're really struggling with an excess of neuropathy
Yes.
that's fighting. So I think they're certainly onto something. I mean, you can kind of see, looking at the Forte results with KR being superior to R, probably that VR is superior to R, especially in high risk disease. But now knowing what we have with the Forte results, I think that I would sooner try and push for KR maintenance. Again, this is tougher to get because it's obviously not fully approved yet, but that's where I think we should be going with maintenance for high risk disease.
Especially with those side effects, yeah.
And then, sorry, the second question was related to
Yeah.
MRD negativity. Right? So super good question. I mean, that study that I showed you earlier from MSK, looking at the continuous maintenance therapy for years and years following induction therapy. I mean, we have patients that are MRD negative for 5 years on lenalidomide maintenance.
Yeah.
Now, it's well tolerated, but it stands to reason, does everybody really need to stay on maintenance that long? We don't know yet, but I think trials like one that we opened at MSK, where we're trialing, for people that sustain MRD negativity for 3 years, that can stop maintenance therapy. We watch closely, see what happens. For trials like Luciana Costa's, where they're de-escalating their induction regimens for people that have MRD negativity. There's a SWOG trial that's looking at a similar kind of, I guess, schema for de-escalating treatment based on MRD negativity. This is the next big question. Everyone's doing really well. How do we stop? Now we're at the point where we're trying, we're over treating everybody. There are some people that we probably de-escalate a little bit.
Okay, wonderful. And I will mention, we did have a session in our relapse refractory chapter about maintenance therapy from Dr. Mohudin in Huntsman.
Oh yes, he's very good. Yeah.
He's incredible. So
Yes.
we send out a resource email along with the recording. So I will make sure to include that recording as well, so that they can have some supplemental.
I would definitely listen to what he says. He's a very smart guy.
Yes, he is. He's awesome. Okay, let me ask a couple more questions.
Sure.
I noticed in the Forte trial, cyclophosphamide, I can't remember how to say that.
Sure, yeah.
Was compared kind of against Revlimid. And I know that there are many specialists or oncologists who hesitate to use Revlimid with patients with kidney involvement. Although I have heard from some specialists that it just depends on the dosing, and that those with kidney problems could actually receive Revlimid. Have you heard anything about this, and what's your opinion on that?
Absolutely. I think I think it's definitely worth touching on this. So I thank you for bringing it up. Um, at least in the US, the way that we treat cyclophosphamide in the frontline setting is that, we've seen a good amount of data, specifically from the Evolution trial that came out of Mayo a few years ago, looking at VRD and VCD. And in general, would say that VRD is a stronger regimen and certainly one that serves itself better to converting into maintenance therapy. You continue the Revlimid. That being said, I mean, you all might know the problems with Revlimid in terms of trying to get it. It's, initially getting approved, getting through REMS, getting the pill delivered to you. That is quite a challenge. And when people are newly diagnosed and they either have a renal problem, something that brings them into the hospital, you often really can't wait for that. And so VCD or Cybor-D, using cyclophosphamide with Velcade, it's a very quick and easy way to get the disease under control. Most people, regardless of renal involvement, even patients on dialysis, at some point will then be able to transition off of the VCD. We get them the Revlimid, and then they can go on the Revlimid. We can adjust the Revlimid or the lenalidomide based on the patient's kidney function. So even if they're on dialysis, I still do try and attempt to get them lenalidomide and switch them off of that cyclophosphamide. Not that it's a bad regimen, just that I think we can do a little bit better.
Yeah, no, that's great. Thank you. That answers a lot of questions that I've had in the past. So thank you for that.
Sure.
Let's see. I was writing down my questions. Such a good presentation. We talked about one of the trials showed, or you even talked about how in your practice, if they achieve MRD negativity, then you normally don't recommend that more toxic stem cell transplant. What about those who are MRD positive, but have very low numbers of MRD positivity? I'm talking, 2 cells in 1,000 or even, 5 in
Absolutely. I think, this is always the problem with data and with cutoffs is that, you try and put people into buckets because that's really the only way to measure responses across, at least with a certain degree of statistical power. But the truth is everybody's disease is different. Every patient is different. There's no one size fits all approach. The best we can do is at this point in time, until we get better at genomics, at whole genome sequencing, all that stuff that's coming down the pipeline in the next few years, the best that we can do to characterize people's disease is to really look at their response following therapy. Because in the end, you can measure cytogenetics, you can measure M protein. Really what matters is how people do when you expose them to therapy. How their disease responds to it is the best predictor. And that's why we love MRD negativity. Mm-hmm. So I would walk it back and say, it's not that I recommend against a transplant if people are MRD negativity. I just think that there is less data to support doing it if you're MRD negative. I'm way more open to a patient saying, I don't really want to do a transplant. I'd say there's not a lot of data to support a transplant at the MRD negative setting. So I think I'd be comfortable in deferring it.
That makes
sense. Other hand, but on the other hand, you look at those MRD positivity rates that came out of all of the trials we talked about, they didn't really make the distinction. It's either MRD positive or not. Right. Sometimes they go deeper. There are a couple of trials that have looked at kind of different levels of cutoff. At the end of the day, any degree of MRD positivity was considered a bad thing. And so for those patients, I would really encourage doing the transplant. Again, it is good therapy. It is safe therapy. There's no reason to be, I guess, I wouldn't say needlessly concerned about it. It does have its long-term issues with it. It is inconvenient. It does require hospitalization sometimes. So there are all of those aspects to it, but it is a tried and true and very well studied treatment for multiple myeloma. Is very effective. And so for patients that are MRD positive, I will usually encourage them to consider doing that.
Awesome. Thank you so much. Carol's wondering, do you support blood tests such as Mayo's for MRD negativity in clinical settings?
Well, in clinical settings, I would say no. I don't think that there is currently an MRD negativity assay in peripheral blood that is approved. I think people are working towards it. I think it's very sorely needed. I mean, doing a bone marrow biopsy every time you need to assess MRD negativity is not tenable. No. Which is why, I don't say that everybody needs it. Sometimes it just gives us a little bit more information. But yes, I think we should be moving towards blood-based testing. Mayo has some nice mass spec-based, protein-based assays. The Spanish group is working on peripheral flow cytometry based testing. But so far, we need to see a little bit more data. We need to have a more standardized assay before we can really consider using that in the clinical setting.
Okay, perfect. Well, thank you for staying with us for a little bit longer. And again, for that presentation, I really did learn so much. So thank you, Dr.
My
Diamond.
pleasure. My pleasure. Anytime.
I will just close with a couple outro announcements, and then we can go on our way. Our next session is going to be on the 21st of October, and we'll be hearing from James Bond, and that is his real name, and his wife, Kathleen, as they share their story. James has been the recipient of 4 stem cell transplants and wants to inspire other myeloma patients with hope. He was also in one of the clinical trials. He was patient 007. So that's a fun serendipitous coincidence that he wants to share with others in order to promote this event. So make sure not to miss this. Our upcoming events you may be interested in, I'll go through them quickly. October 5th is our follow-up of last month's Medicare open enrollment session. This is going to be purely Q&A. Diana wants to hear from you. When you sign up for this event, you will be receiving an email that says, please enter your questions beforehand. We want to make sure that we can analyze all the questions that are asked to be able to answer them correctly during the session. On the 6th is our Muscles for Myeloma Fitness chapter. We're going to be doing a live step aerobics workout with Lindley, who is our chapter lead. On the 7th at 3 p.m. Eastern or at 1 p.m. Eastern is our stem cell transplant chapter. That's the emotional aspects of stem cell transplants. And Louise Lavin's going to be joining us to discuss how we can overcome and manage these emotional aspects that can come with such a life-changing procedure. The 13th at 1 p.m. Eastern, I'll correct those before I send them out, is the relapse refractory myeloma patients chapter. We're going to be hearing from Janssen's patient advocacy group about how they provide patient support and help make treatment more affordable. The link to sign up for any of those events and even more events that I have not mentioned is found at the bottom of the screen and will be sent out in our follow-up email. Again, a thank you to our sponsors, Bristol Myers Squibb, Takeda Oncology, Karyopharm Therapeutics, Adaptive Biotechnologies, Oncopeptides, Janssen Oncology, AbbVie, Sanofi, Amgen Oncology, and Genentech. And thank you to each of you for helping us build a strong myeloma crowd community. And thank you again, Dr. Diamond, for your shared time and knowledge. We hope that you have a great rest of your day. Thank you.
Thank you.